Hey guys, it's Ibreez. How should I actually start this? Or do we do? Hey guys, it's Ibreez, and this is another input into our IMT diaries. I'm on a night shift, so I thought I'd walk you all through a day in the life of an IMT on nights. So at Derriford, where I'm currently doing my internal medicine training, we have 3 doctors that we keep on the night shift. We have a cover A, a cover B, and a cover C for the cover, and then those who have the acute medicine rotations, they do the take or the admission part. And that's a whole nother thing. When we get to MAU, we will cover that part. But currently I'm in care of the elderly or geriatric medicine, so I do cover shifts. The way my cover shift works is actually pretty fantastic. So they give me 2 things. The first thing they give me, I always keep in my handy dandy pocket, is my pager or my bleep. This thing, it stays relatively silent for me throughout the night because they give me something even more awesome. It's known as a hand bleep. So my hand bleep, it says hand bleep on, it's got my name on it, it's got my login that is personalized to me. Before my shift starts, and that's the number that stays with me throughout my rotation in this hospital. Essentially what happens is if I get a job or a call, it'll come up here, and then I click it and it gives me a brief synopsis of what needs to be done. It could be, a patient needs a cannula, I need to review a patient who's unwell, or something to that extent. And those are for the wards that I cover. Currently, I'm covering, let me see, I've got my list here, how many wards I have. 1, 2, 3, 4 main wards and then some outlier wards. And by outlier wards, those are just kind of like overflow wards. There might be just one extra ward where they don't necessarily need to fill it completely with medical or surgical or gynecological or obs patients. So what they'll do is they'll kind of allocate a certain amount of beds for each of those specialities. And like for instance, I'm covering medicine patients, so there might be 5 or 6 patients on those wards that I need to be aware of in case something happens during the night. But for the most part, I mean, it's pretty good having a hand bleep rather than being paged every single time. I'm one of those people that even if I decide to take a nap or take a break, just hearing a bleep in the middle of the night, it can be pretty antagonizing. It's a very harsh sound. It's not exactly something you want to be jolted awake by. But beyond that, going onto the ward, you get a really nice S-bar from the nurses or any other healthcare professional who's there who tells you what's going on. And on the hand bleep, they also have that opportunity to let us know what it is they want doing, so that even if when we get to the ward they might be busy with something else, I can get to what I need to get to and see what I need to see because they've already explained and outlined whatever it is they want me to do in that much time. So the way my shift works, I show up at 9:30 in the evening and then we've got a handover. All the doctors throughout the day, the cover doctors, we have 7 cover doctors who basically all the wards in the hospital, or the medical wards, are split up amongst them, and then that's condensed down to 3 doctors for the night, and they hand over anything that they think we need to know for the night. Maybe we have to make sure a scan is done, or act on a scan, or act on certain bloods, or maybe there's something that the regs need to know. And we have 2 regs with us during the night, so that's also extremely helpful. Especially if it's one of those nights where anything and everything can kind of happen. Usually the cover A is somebody who will carry the crash bleep, or the bleep that basically informs a person if there's a MET call or a medical emergency team call, or essentially a cardiac arrest or peri arrest or something to that extent, where we need to have a bunch of people come out there, doctors, nurses, all the staff, and see how the patient's doing, because for some reason their vitals are not within the optimal range anymore. It doesn't always have to be the cover A doctor, it can be whoever feels the most confident, because sometimes the cover A doctor might be an FY1 or an FY2, or it might be somebody who just, it's their first night and they don't want to take that kind of responsibility on the first night. But it's up to you, and it's up to everyone you're working with, something that you can voice if it's something that you want to do. I'm not carrying it tonight, but I will be carrying it on my next set of nights. So it's a good kind of anxiety, I guess, thinking that you've got that kind of responsibility in your hands. But the important thing to always remember in these situations is that you're not alone if something like that were to happen. The reg will come up, the acute care team comes up, the nurses are there. I mean, anyone and everyone that you would need to be there all the people who need to be there in case something goes haywire will be there. Even if you're the first person to arrive and you have no idea what you're gonna do next, just think back to your ALS. Just go through the ABCDEs every single time with that patient. Try and get as much information as you can about what's going on with that individual, and then when more people start coming onto the scene, just try and find where your role is. Some hospitals will also make sure beforehand, like during the handover, your roles are already mentioned in those situations so that there isn't that kind of confusion whenever a met call or cardiac arrest happens, like who's doing the ABGs or who's going to do chest compression. So if that's how it works for you all, then you're set. You don't have to worry about anything. But remember, if you are ever confused or unsure about what you need to do, just ask, be loud, mention that, hey, this is what I want to do, this is what I'm going to do, so that it doesn't get kind of lost in everything that's happening. And if you feel overwhelmed, never be concerned about just taking a step back and seeing what else you can do and then trying to get back in once you feel like, you've recovered.
Say hi. Say something.
I don't have any jobs right now. I'm just fantastic, and it is currently
Getting down. 7th floor.
2:40 a.m. Almost there.
Almost there?
Almost there.
Doors opening.
So,
Post night, yo. Look at that glow.
talk about your experience, Ibreez.
My experience. Well, today was alright. I think all things considered, the patients were more or less stable. They had a lot of admissions, so they took us down for a little bit to help with clerking and patients. But at least in the handover in the morning, we got to finish quickly because we pretty much managed everyone. Nothing really needed to be handed over. So that's always open.
It's true.
And the lovely, leisurely, refreshing walk home. So now what to do, after night? Some people like to go straight to sleep. Some people don't. I love the belief it doesn't make sense to go to sleep straight away. Get a little work done, hit the midday mark, then get some sleep, because then you don't mess up your whole timeline. Have a good breakfast or whatever, lunch, and crash. I'm very proud though, I did not have any caffeine this entire night. It is a rare miracle.